Indications and usage. BRUKINSA, zanubrutinib, is a kinase inhibitor indicated for the treatment of adult patients with chronic lymphocytic leukemia, CLL, or small lymphocytic lymphoma, SLL. There are no randomized controlled trials between BRUKINSA and acalabrutinib. MAICs are hypothesis-generating and do not establish superior efficacy or safety of one drug over another. The results should be viewed in the context of the limitations of the analysis and randomized clinical trial data. There is a potential for bias resulting from the strong assumption that cross-trial differences can be entirely explained by variables selected for matching. Select safety information about BRUKINSA. Serious adverse reactions, including fatal events, have occurred with BRUKINSA, including hemorrhage, infections, cytopenias, second primary malignancies, cardiac arrhythmias, hepatotoxicity, including drug-induced liver injury, and embryo-fetal toxicity. In the pooled safety population, N equals 1,729, the most common adverse reactions, greater than or equal to 30%, including laboratory abnormalities, in patients who received BRUKINSA, were neutrophil count decreased, 51%, platelet count decreased, 41%, upper respiratory tract infection, 38%, hemorrhage, 32%, and musculoskeletal pain, 31%. Please see full important safety information at end of the video and full prescribing information.
I'm Dr. Shadman, and in this short video, I will walk you through the methodology for Matching Adjusted Indirect Comparison, or MAIC, and will also provide an example for such analysis. Matching Adjusted Indirect Comparison, or MAIC, is a well-established statistical method that is commonly used to compare the efficacy outcomes of different drugs, where there is no head-to-head trial directly comparing them. MAICs are hypothesis-generating and useful to compare different drugs when there is no head-to-head trial, provided that they are conducted with appropriate methodological rigor and the potential biases have been minimized. MAICs can be conducted in two main ways: anchored and unanchored comparisons. Anchored MAICs are possible when there is a common comparator drug between the two trials that you're indirectly comparing. For example, here we are interested in conducting a MAIC analysis of drug B versus drug C. Drug B has been compared to drug A in a clinical trial, and also drug C has been compared to drug A in another clinical trial. This means drug A becomes your anchor in the MAIC. Anchored MAICs are generally considered to be more robust than unanchored MAICs. However, common comparator arms are not always available when comparing the trials, in which case unanchored MAICs are valid and may also be used. The MAIC is unanchored when there is no common comparator. Let's look at the MAIC process together. We are interested in comparing the outcomes between a study A, for which the published aggregate data is available, and the study B, for which we have access to the individual patient-level data. The characteristics of the average patient in the study B are different to the patients in the study A. Therefore, any comparisons between the two outcomes of the two trials will be flawed. However, using the MAIC methodology, we can match the characteristics of patients in the study B to those published in the study A. Here we take the individual patient-level data from study B. Let's say in this case we have only 6 patients as an example, and assess each patient based on how close they are to the average patient from a study A. Using the MAIC and statistical methods, we can match the available individual patient data from a study B against the published aggregate patient from a study A. Based on how close each patient in the study B is to the average patient in the study A, they get a weight assigned to them. The closeness of individual patient of a study B against the aggregate patient of a study A is assessed based on a set of key baseline characteristics. After matching, the effective sample size is 4, meaning that the number of patients in the study B reduced from 6 to 4 as a result of the matching. This sample now resembles the study A more closely, allowing for a better balanced indirect comparison to be made between the two outcomes of the two trials. With the new matched population, we can now go ahead and compare the endpoints such as progression-free survival and overall survival with more assurance. Now let's look at this concept in more detail. We want to compare the outcomes of Study A with Study B. Study A has 90 patients and Study B has 100. If we simply compare the 24-month PFS endpoint without matching these two studies, it appears that both treatments result in comparable landmark PFS rates. However, we know from the three baseline characteristics that are detailed here that the average patient is different between the trials, making any comparison between the outcomes flawed. To make this comparison more balanced, we need to match the individual patient data from a Study B to the published aggregate data from a Study A. The published aggregate data of any study will typically have a selection of key patient characteristics, and these characteristics will be averaged or aggregated. For example, we know the mean age of patients on the Study A, but we don't know the age of each patient. We have the full raw individual patient data for Study B, which can be weighted using the MAIC methodology. Based on the three characteristics selected, we assign weights to each individual patient from a Study B. This results in a reduction from 100 patients in the Study B to an effective sample size of 65. This weighted population in the Study B now much more closely resembles the aggregate patient data from the Study A. Now we can compare the 24-month PFS across the two trials with more confidence. Now let's look at the real-life examples to better understand the use of MAIC. This analysis compared the outcome from the Alpine and Ascend randomized controlled trials, which both investigated the efficacy of a BTK inhibitor, zanubrutinib in Alpine and acalabrutinib in Ascend, in patients with relapsed refractory CLL. There's currently no head-to-head clinical trial data comparing zanubrutinib versus acalabrutinib in relapsed refractory CLL, and so we can only make indirect comparisons between the outcome of these trials. The Alpine study compared zanubrutinib versus ibrutinib, and the Ascend study compared acalabrutinib versus idelalisib plus rituximab or bendamustine plus rituximab. As there's no common comparator between the two trials, this comparison would be an unanchored one. In this example, we matched 327 patients from the Alpine zanubrutinib arm, for whom we have individual patient data, against published aggregate data of 155 patients from the Ascend acalabrutinib arm. Ascend was initiated before Alpine and therefore has longer follow-up. Ascend also had slightly different eligibility criteria, resulting in key differences between Alpine and Ascend patient populations. In the first step of the analysis, we selected Ascend and Alpine trial data cutoffs that have median follow-up periods that are as close to each other as possible. Then we filtered out zanubrutinib patients from Alpine whose data on the selected baseline characteristics were missing. This resulted in a reduced sample size of 308. Next, we applied weights to this population based on how close each patient is to the average Ascend patient. This reduced the sample size further to an effective sample size of 185 patients, which is 60% of the filtered population. This resulted in a more balanced population that could be used to calculate the relative efficacy measures between zanubrutinib and acalabrutinib. Let's go back and question the comparability of the population across the two trials. What criteria do we use to decide if patients of Study B are close to patients in Study A? This is based on the set of baseline characteristics included in the analysis. It is important to have full visibility of baseline characteristics included and excluded from the MAIC analysis. Here you see the description and example of two main types of variables to be included in the analysis: prognostic and predictive markers. Prognostic factors are variables relating to general disease and patient outcomes regardless of treatment. On the other hand, predictive factors are variables that affect treatment effect. For unanchored comparisons, there's a need to include a comprehensive list of both types of baseline characteristics. In this example, you can see the variables included in the main analysis. The unadjusted main analysis will demonstrate the relative efficacy of zanubrutinib versus acalabrutinib without any adjustment for patient characteristics. The best-case adjusted scenario matches the population of zanubrutinib in Alpine against acalabrutinib in Ascend with respect to all the variables that are shown with a tick mark. The selection of these variables was based on a review of the prognostic and predictive factors in Alpine and Ascend considering the trade-off between the number of variables matched and the effective sample size. To test the sensitivity of analysis with respect to the selected variables, a variety of scenarios are also presented, including different sets of variables used for matching. Trial follow-up is a known treatment effect modifier. Where possible, it's important to select and compare data cutoffs that have similar follow-up periods. Let's look at the timelines of Ascent and Alpine. The yellow lines here show the timelines of each trial, with red boxes indicating different data cutoffs. The latest cutoff we have for Alpine is highlighted in red and has a median follow-up of 38.7 months. Ascent has several published data cutoffs, and the cutoff which has the closest median follow-up to Alpine is 36 months, also highlighted in red. And this was selected for the MAIC analysis. In addition to ensuring that the follow-up periods for each trial are as comparable as possible, it is essential to take into account the impact that COVID-19 epidemic may have had on each of these trials. This figure shows the overlay of the timing of the trial versus COVID pandemic and its global peak and the number of COVID-19 cases. You can see that the majority of Alpine trial was conducted during COVID-19 pandemic. This had a major impact on patients in the study. On the other hand, the majority of the Ascent trial was conducted pre-COVID-19. Only a few months of 2020 data cutoff coincide with the pandemic, with no overlap between the peaks of COVID-19 cases. Because of these reasons, the current analysis adjusts for the impact of COVID-19 related events on the Alpine population. After selecting data from Ascent and Alpine that has a comparable median follow-up, adjusting for the impact of COVID-19, and weighting the individual patient data from Alpine to more closely match the published Ascent aggregate data, we can now begin comparing efficacy outcomes with more assurance. Here you can see the PFS plots for the acalabrutinib treated patients shown by turquoise line and zanubrutinib treated patients before and after matching shown by purple and red lines respectively. Before matching, the zanubrutinib curve is slightly higher than the acalabrutinib curve with a hazard ratio of 0.77 with no statistical difference. After matching, we see that the curve for zanubrutinib has shifted upward and the hazard ratio is now 0.68, and the difference between zanubrutinib and acalabrutinib curves is statistically significant. This indicates improved progression-free survival for zanubrutinib-treated patients compared to acalabrutinib-treated patients when Alpine population is matched to Ascent. Here, the MAIC had less impact on the overall survival estimate. The base case adjusted population hazard ratio remains similar to the unadjusted population. However, as you can see the hazard ratio reported on the figure, the OS hazard ratio lost significance after matching. In this table, the results for base case as well as 6 different sensitivity analyses are presented. The bold values imply a significant benefit for zanubrutinib. As you can see, the odds of complete response remain significantly in favor of zanubrutinib across all the scenarios. Other results demonstrate the same trend as the base case analysis. This table also demonstrates a good example of providing transparency when reporting the MAIC results. You can clearly see what impact different assumptions have on the results. Note that matching for all variables will negatively impact the effective sample size by reducing the power of the analysis, and this is the case in scenario number 6. In this study, we did not compare safety of zanubrutinib versus acalabrutinib, given different treatment exposure times across the 2 trials. Safety of a drug is best evaluated via meta-analysis that uses all available evidence across all indications. A meta-analysis presented by the Mayo Clinic group at the European Hematology Association meeting in 2023 combined the safety results of 61 trials, including a total of almost 7,000 patients who received ibrutinib with or without anti-CD20 antibodies, acalabrutinib, or zanubrutinib. This study extensively analyzed the adverse event profiles of zanubrutinib and acalabrutinib across several indications and reported differences between the 2 treatments. The mentioned study provides a robust basis to compare the adverse event profiles of zanubrutinib and acalabrutinib as it includes all available data. In conclusion, this MAIC suggests that Progression-free survival is significantly improved for zanubrutinib compared to acalabrutinib. Overall survival showed a potential improvement for zanubrutinib, although after adjustment, the statistical significance was not observed. Complete response favored zanubrutinib compared to acalabrutinib in all the scenarios. The results for the sensitivity analysis are robust and consistent with the base case. It must be noted that in any MAIC, there is a potential bias resulting from a strong assumption that cross-trial differences can be entirely explained by variables selected for matching. Here we discuss some of the challenges encountered, such as the effect of COVID-19 pandemic. As a last word, I would like to emphasize that while MAICs provide an established and scientific basis for generating hypotheses with regards to treatment efficacy across trials, the gold standard of obtaining relative efficacy estimates remains randomized controlled trials. But as we know, there's no randomized trials comparing zanubrutinib and acalabrutinib. MAICs are hypothesis generating and do not establish superior efficacy or safety of one drug over another. The results should be viewed in the context of the limitations of the analysis and data from randomized trials. Thank you much for your attention.
Important safety information about BRUKINSA, zanubrutinib, capsules, warnings and precautions, hemorrhage. Fatal and serious hemorrhage has occurred in patients with hematological malignancies treated with BRUKINSA. Grade 3 or higher hemorrhage, including intracranial and gastrointestinal hemorrhage, hematuria, and hemothorax, was reported in 3.8% of patients treated with BRUKINSA in clinical trials, with fatalities occurring in 0.2% of patients. Bleeding of any grade, excluding purpura and petechia, occurred in 32% of patients. Bleeding has occurred in patients with and without concomitant antiplatelet or anticoagulation therapy. Co-administration of BRUKINSA with antiplatelet or anticoagulant medications may further increase the risk of hemorrhage. Monitor for signs and symptoms of bleeding. Discontinue BRUKINSA if intracranial hemorrhage of any grade occurs. Consider the benefit risk of withholding BRUKINSA for 3-7 days before and after surgery, depending upon the type of surgery and the risk of bleeding. Infections. Fatal and serious infections, including bacterial, viral, or fungal infections, and opportunistic infections have occurred in patients with hematological malignancies treated with BRUKINSA. Grade 3 or higher infections occurred in 26% of patients, most commonly pneumonia, 7.9%, with fatal infections occurring in 3.2% of patients. Infections due to hepatitis, B virus, HBV, reactivation have occurred. Consider prophylaxis for herpes simplex virus, pneumocystis jirovecii pneumonia, and other infections according to standard of care in patients who are at increased risk for infections. Monitor and evaluate patients for fever or other signs and symptoms of infection and treat appropriately. Cytopenias. Grade 3 or 4 cytopenias, including neutropenia, 21%, thrombocytopenia, 8%, and anemia, 8%, based on laboratory measurements, developed in patients treated with BRUKINSA. Grade 4 neutropenia occurred in 10% of patients, and grade 4 thrombocytopenia occurred in 2.5% of patients. Monitor complete blood counts regularly during treatment and interrupt treatment, reduce the dose, or discontinue treatment as warranted. Treat using growth factor or transfusions as needed. Second primary malignancies. Second primary malignancies, including non-skin carcinoma, have occurred in 14% of patients treated with BRUKINSA. The most frequent second primary malignancy was non-melanoma skin cancers, 8%, followed by other solid tumors in 7% of the patients, including melanoma in 1% of patients, and hematologic malignancies, 0.7%. Advise patients to use sun protection and monitor patients for the development of second primary malignancies. Cardiac arrhythmias. Serious cardiac arrhythmias have occurred in patients treated with BRUKINSA. atrial fibrillation and atrial flutter were reported in 4.4% patients treated with BRUKINSA, including grade 3 or higher cases in 1.9% of patients. Patients with cardiac risk factors, hypertension, and acute infections may be at increased risk. Grade 3 or higher ventricular arrhythmias were reported in 0.3% of patients. Monitor for signs and symptoms of cardiac arrhythmias. For example, palpitations, dizziness, syncope, dyspnea, chest discomfort. Manage appropriately, and consider the risks and benefits of continued BRUKINSA treatment. Embryo-fetal toxicity. Based on findings in animals, BRUKINSA can cause fetal harm when administered to a pregnant woman. Administration of zanubrutinib to pregnant rats during the period of organogenesis caused embryo-fetal toxicity, including malformations at exposures that were 5 times higher than those reported in patients at the recommended dose of 160 milligrams twice daily. Advise women to avoid becoming pregnant while taking BRUKINSA and for 1 week after the last dose. Advise men to avoid fathering a child during treatment and for 1 week after the last dose. If this drug is used during pregnancy, or if the patient becomes pregnant while taking this drug, the patient should be apprised of the potential hazard to a fetus. Hepatotoxicity, including drug-induced liver injury. Hepatotoxicity, including severe, life-threatening, and potentially fatal cases of drug-induced liver injury. DILI has occurred in patients treated with Bruton tyrosine kinase inhibitors, including BRUKINSA. Evaluate bilirubin and transaminases at baseline and throughout treatment with BRUKINSA. For patients who develop abnormal liver tests after BRUKINSA, monitor more frequently for liver test abnormalities and clinical signs and symptoms of hepatic toxicity. If DILI is suspected, withhold BRUKINSA. Upon confirmation of DILI, discontinue BRUKINSA. Adverse reactions. The most common adverse reactions, more than or equal to 30%, including laboratory abnormalities. In patients who received BRUKINSA, N equals 1,729, are decreased neutrophil count, 51%, decreased platelet count, 41%, upper respiratory tract infection, 38%, hemorrhage, 32%, and musculoskeletal pain, 31%. Drug interactions. CYP3A inhibitors. When BRUKINSA is co-administered with a strong CYP3A inhibitor, reduce BRUKINSA dose to 80 milligrams once daily. For co-administration with a moderate CYP3A inhibitor, reduce BRUKINSA dose to 80 milligrams twice daily. CYP3 inducers. Avoid co-administration with strong or moderate CYP3A inducers. Dose adjustment may be recommended with moderate CYP3A inducers. Specific populations. Hepatic impairment. The recommended dose of BRUKINSA for patients with severe hepatic impairment is 80 milligrams orally twice daily. Indications. BRUKINSA is a kinase inhibitor, indicated for the treatment of adult patients with chronic lymphocytic leukemia, CLL, or small lymphocytic lymphoma, SLL. Please see full prescribing information, including patient information.